Well, good afternoon, I guess, or morning, depending where you are in the country. My name is Greg Penny, and I'm the Director of Programs here at the Canadian Public Health Association. I will be moderating this afternoon's oral abstracts portion of this, so please use the Q&A feature down at the bottom of your screen. The way this is going to work is just like an in-person oral abstract. We'll give the presenters about 10 minutes to present. We'll do a 5-minute Q&A, and then we'll move to the next presentation. I just want to start by thanking Brett and Dana for their presentations this morning. I think it's given us an opportunity to look at things a very different way and really know that there are different ways of knowing and thinking about these different topics. So to get us started this afternoon, we have Quinn Stewart, who's going to be presenting her work on trends in tick-borne disease surveillance in British Columbia. Quinn, over to you.
Awesome. Can everyone see my screen? Can I get a confirmation, please?
We can see it.
See you.
Awesome.
Can't see. We can see you. Oh, I'm sorry. I'm looking at the wrong screen. I'm seeing two different things. Sorry.
Okay, perfect. So thank you, everyone. My name is Quinn, and I am an epidemiologist at the British Columbia Centre for Disease Control. And as mentioned, I will be presenting on the trends in tick and tick-borne disease surveillance in British Columbia. And I'd also like to acknowledge my co-authors, Doctors Aaron Fraser and Mayank Singhal, as well as the Musqueam, Squamish, and Tsleil-Waututh nations whose ancestral and unceded territories I'm speaking from today. Now, first, I would like to talk about what we're seeing in terms of Lyme disease in British Columbia. Now, for context, Lyme disease is the most common tick-borne disease in Canada. However, it is not the only tick-borne disease in Canada. So in BC to date, we've seen 213 total confirmed Lyme disease cases. However, only around 101, which are considered to be locally acquired based off of the exposure information available. And this translates to between 1 to 14 locally acquired confirmed cases per year, which, if you know anything about Lyme disease in Canada, specifically Lyme disease in the eastern provinces, this is comparatively low. Now, looking at some demographic characteristics of our locally acquired Lyme disease cases, there were slightly more males than females at 57% of our cases identifying as male and 43% identifying as female. And in terms of age, we see that the majority of our cases fall into the 45 to the 49-year-old age group, followed secondly by the 60 to 64-year-old age group. Now, at the BC CDC, we operate a multifaceted surveillance system of BC tick populations that consists of both passive as well as active elements. And I will be focusing on the findings of these components in blue, which are the regularly occurring surveillance activities. However, I will note that in orange, we do have a number of special projects that also contribute to our surveillance system. So starting on the far left, we have participated as a province in the ETIC program since 2021. And for those of you who don't know, ETIC is actually a platform where members of the public can submit photos of ticks that they find on themselves, on their pets, as well as free in the environment to be identified by experts through an app on your cell phone or the website etic.ca. Moving over now to our second component that constitutes our regular passive tick surveillance activities, and this is submissions of ticks from physicians and veterinarians found on humans and animals, respectively, to the BC CDC Public Health Laboratory for identification. And additionally, any Ixodes ticks identified through this process undergo testing for Borrelia species. Now, moving over to the active leg of our surveillance program, we have a collaboration with the Canadian Lyme Disease Research Network that was initiated in 2019 and consists of active drag sampling, as well as testing any captured Zoetis ticks, those being the black-legged ticks, for those 5 pathogens listed there on this screen. So getting into some findings from our ETIC surveillance activities on the screen here, the majority of our ETIC submissions were identified to be dermacenter ticks, and a minority, or 30%, were identified to be Zoetis ticks. And of these submitted Zoetis ticks, the large majority were identified to be Zoetis pacificus, which is commonly known as the Western black-legged tick. In terms of geographic distribution, we see that the majority of our dermacenter submissions to ETIC came from that purple region there in the map and the top graph, which is interior health, and that is the region of the province that is just west of the Rocky Mountains and north of Washington State. Now, in contrast to our dermacenter distribution, we see that our Zoetis black-legged tick submissions were most numerous from Island Health and Vancouver Coastal Health, those regions that are in the blue and green, which are the southern coastal regions of British Columbia. Now, this looks very similar, but this is actually what we see in terms of our geographic distribution of our passive tick submissions to the BC CDC Public Health Laboratory. Now, interestingly enough, Zoetis tick submissions actually represented a slight majority at 67% of all submissions compared to dermacenter, which only represented 30%. And if you remember from the previous slide, this is actually the opposite of what we saw with ETIC, where dermacenter ticks represented the majority of the submissions. However, as was the case with the ETIC data, Zoetis pacificus ticks constituted the vast majority of our Zoetis tick submissions at 86% of all Zoetis ticks submitted. We also observed identical geographic distribution with those dermacenter ticks dominating the interior regions of the province in the purple there, and Zoetis ticks found along the coast of the province. Now, for those of you who don't know, most Lyme disease in Canada is caused by the pathogen Borrelia burgdorferi, and this slide shows that the number of these Zoetis ticks that are submitted to the BC CDC Public Health Laboratory that tested positive for Borrelia burgdorferi. So between 2002 and 2021, we saw between 0 and 5 Zoetis ticks testing positive. However, this past year in 2022, we saw quite a jump to 10 Zoetis ticks testing positive, and this translates to 1.26% of all submitted Zoetis ticks for that year. Now, moving over to our findings of our active drag sampling, 140 Zoetis ticks were submitted for pathogen testing between 2019 and 2022. However, no ticks tested positive for any pathogen in 2020 or 2021. In 2019, we saw a single tick test positive. That is a tick collected from Metro Vancouver, and that tested positive for babesia microti, which is a pathogen associated with the disease babesiosis. And in 2022, we did see a number of ticks test positive for many things. Zoetis pacificus ticks collected from South Vancouver Island tested positive for babesia oticolii, which is associated with babesiosis in white-tailed deer populations. Anaplasma phagocytophilum, which is associated with the disease anaplasmosis, and Borrelia burgdorferi, which of course is associated with Lyme disease. In addition, we did see 2 more detections of babesia microti in those Zoetis angustus ticks that was also collected from Metro Vancouver. However, all 3 of these positive detections did come from different sampling regions of Metro Vancouver. So while Anaplasma phagocytophilum and Borrelia burgdorferi have been known to be present in British Columbia prior, these findings represent the first detections of babesia microti and babesia oticolii in BC tick populations, and really highlights the changing risk profile of tick-borne diseases in the face of climate change. So just wrapping up, I would like to show you this slide here, which compares the seasonality of Lyme disease cases compared to the seasonality of our passive Zoetis tick submissions from humans, from both ETIC in the middle there and the BC CDC Public Health Laboratory on the bottom. So kind of translating this humans generally encountered Zoonosis ticks in the summer months. In particular, we did see big peaks in May for both e-tick and public health laboratory submissions. However, our Lyme disease cases tended to be reported later in the summer. And explanations for this delay likely include a combination of both the incubation period, which for Lyme disease typically ranges from 3 to 30 days, but can be longer. And that is the time between when you contract the disease and when you present with symptoms, and also delays associated with accessing healthcare and laboratory testing. So thank you all for listening to my presentation. Lots of acknowledgements. This could not be possible without all those people listed on the screen there. I will keep my screen up for sharing and move over to any questions.
That's great. Thank you very much, Quinn. So again, everyone, you can use the Q&A to ask questions. So I do have a couple of questions that sort of arose. So in your very first slide, you obviously, a lot of the cases you identified were resulting of travel. Were you able to determine where people were traveling to? In my head, I'm thinking everybody went to Ontario and got Lyme disease and came home. But have you looked at that component of where people were traveling to?
Yeah, so that's actually a very good deduction. So Ontario is responsible for a lot of our cases, as well as Nova Scotia. This year, we've seen that Nova Scotia have reported a large number of Lyme cases, and a lot of our cases are from there. However, we do see a few cases that are coming from travel to Europe, and those are typically different types of Borrelia, so like Apicellii and Guarinii.
Great. The other question that I had when you were talking about the different and the derma and the zodies and where they're occurring in the province, and I realize the boundaries are the physical political boundaries, but have you thought any more about sort of why they're clustered in some of those areas, like why obviously Interior and Vancouver Island have such a higher rate compared to other parts of BC?
Yeah, so I'm not a vector biologist, but I do know that there's different environmental and species needs for those two ticks. Different tick species have different characteristics such as being soft-shelled or hard-shelled that really makes them accustomed to certain environments. So in the interior, we typically see harsher winters, it's colder, a little bit drier, whereas on the coast, it's a little bit more hospitable for tick species.
Great. I don't see any other questions. Is there anything else you would like to touch on, Quinn, before we move on?
I don't think so.
Great.
Yeah, thank you, everyone. I'll stop sharing and leave it over to the next presenter.
Great. Thank you very much, Quinn.
Thank you.
So our next presenter is, I think they're coming online here. So our next presenter is going to be Ariane Adam-Poupart. Is Ariane online yet? Oh, there we are. I'll just give Ariane just a second to connect all the technology. So Ariane is going to be presenting the scientific program aiming at building Quebec's capacity to adapt to the impacts of climate change on zoonoses. Thank you for joining us, Ariane, and over to you.
Thank you very much. Now you hear me well?
Perfect.
Excellent. I will share my screen. Just let me know if you see everything correctly. Let's do this first. Do you see my screen?
I see your screen. Yep, there you are in your presentation mode.
Excellent. So, bonjour à tous. I'm very happy to be with you today. My name is Ariane Adam-Poupart. I am an expert scientist advisor at INSPQ, so the Public Health Institute of Quebec. I am also the coordinator of the team responsible for zoonoses there. And I'm very happy to be with you to present a scientific program that we have in Quebec that aim at enhancing Quebec resilience to zoonotic diseases in the face of climate change. just move this. Okay. So this is the plan of my presentation. I will give you a little context regarding the program. Then I will explain you the objective of the program. I will explain you the operationalization and the main activities of the program, the main program outcomes, a conclusion, and finally, acknowledgement. So regarding the context, well, in Quebec, the most important zoonoses for public health are mainly tick-borne diseases, mosquito-borne diseases. We have rabies that we found in some animals such as bats and fox, and we have also many enteric zoonoses such as Campylobacterios and Salmonellosis. In the recent year, we have seen the progression of various of these zoonoses. The most important example is Lyme disease, where we see year after year an increase in the number of cases of Lyme disease declared. As you all know, well, there will be an influence of the climatic and ecological changes on the situation of zoonoses. It will be like this in Canada as in Quebec. So for instance, the increase in temperature and precipitation will have an impact on the propagation and the distribution of some of the zoonoses. And the climate change will bring changes in human activities, and this could lead to extended exposure period. So to address all this, well, INSPQ has developed a scientific program specifically dedicated to this issue to strengthen Quebec capacity to adapt to the impact of climate change on zoonoses. The objective of the program are the following. So it's to produce and transfer scientific knowledge to support the decision of the public health authorities and decision makers, and also to optimize public health practices regarding the adaptation to the impacts of climate change on zoonoses. So this slide describes how the program is functioning and the main activities. So the program is managed by a scientific committee. The name of the committee is Scientific Committee on Zoonoses and Adaptation to Climate Change. In this committee, there is a president. There is me as the team coordinator and also as a professional. We have the chef unit, and there are many of my colleagues who work on 5 different teams. So we have tick-borne diseases work, mosquito-borne diseases work, enteric zoonosis work, rabies work, and also specific work on climate change impact and adaptation. And to achieve the goal of the program, we work with various external partners. So as you can see, we have a group of experts that support the work for tick-borne diseases, mosquito-borne diseases, and enteric zoonoses. We work with a provincial scientific committee for the rabies work, and we have a group that we call Observatory, l'Observatoire multipartite québécois sur les zoonoses et l'adaptation au changement climatique, which is a group where we find experts and decision makers. And this group is really supported all the work that we do on climate change impact. We try to implement the One Health approach in each of our expert group and in the Observatoire. So in this group, we try to have expertise on human health, animal health, and science, environmental sciences. And lastly, well, the main activities that we are doing are surveillance and risk assessment, scientific literature monitoring, and research project. So before showing you the outcomes of the program, I thought it was very important to show you who are behind the work of this program. I don't have the time to present all of my colleagues, but I believe if ever you read a publication from Quebec, from INSPQ on zoonoses, you will be able to look at the PowerPoint and see who are the authors of this publication. So if we talk about the main program and outcomes, basically the outcomes are knowledge development and knowledge transfer. So in the next slide, I will give you a little more example of all of these outcomes. The first big outcomes is the knowledge development through surveillance activities. So basically the scientific committee that I showed you is a committee that has the mandate from the Ministry of Health to conduct surveillance activities and to implement surveillance program. So because of this mandate, we have the capacity to produce and publish provincial portraits of surveillance data. We do that annually for tick-borne diseases and also for mosquito-borne diseases. And we have published portraits for a longer period, namely for enteric zoonoses, but also for Lyme disease and for West Nile virus. And because of the mandate of surveillance, also we have the capacity to conduct risk assessment and to create and publish risk maps of acquisition, for instance, of Lyme disease and also rabies. And those maps are there to support the prevention measures that would be implemented by public health authorities, such as communication or such as giving indication for post-exposure prophylaxis. So I give you links here if ever you want to visit our websites and look at the work that we have done with the surveillance activities. The second big outcomes is the knowledge transfer to public health actors that we do through various activities. So I give you 3 examples. We have a monthly scientific literature monitoring bulletin that we publish. So every month we publish a list of the relevant publication from the scientific literature and the gray literature, and the publication that we identify are the more relevant for public health, and they are on the 5 themes that I've mentioned earlier. So tick-borne diseases, mosquito-borne diseases, enteric zoonoses, rabies, impact of climate change, and we also have one list for avian flu publication. We also have a series of 9 webinars that are ongoing since the last month. So the webinar are on zoonoses and climate change. The target audience is mainly the professional from public health institution. If ever you're interested, you can register for the next one. The next one will be next week. I think it's Wednesday or Thursday, and it will be on the surveillance of Lyme disease in Quebec. Lastly, we also produce and we have published online tools to support public health practices. So the illustration that you have here on the right-hand side of the slide are an example. We produced informative pamphlets for workplaces where we explain the risk and we explain the prevention measure to prevent the tick bites and the mosquito bites in the workplace. These pamphlets can be downloaded from the website, they can be printed, and we know that public health professionals in Quebec use these tools and bring them with them when they are going in the workplace to communicate risk and prevention measures. Another outcome is actually the knowledge development through research project. I list you a few research projects here. Some of them are published and some of them will come soon. So we have conducted training of ambassador in various parks in Quebec. The training was regarding the prevention and surveillance activities of ticks and mosquito-borne diseases. So basically we train ambassador for them to be able to collect tick and mosquito in their work environment and for them to be able to communicate the risk and the preventive measures regarding tick and mosquito-borne diseases. So you have a list of references if ever you're interested in our work. We also have conducted research on the burden of Lyme disease expected by 2050 in the context of climate change in Quebec. So this should be published very, very soon in the CCDR. And lastly, we are working on 2 very nice projects where we will develop projection maps of the distribution of zoonoses, integrating the expected global warming by 2030, 2050, and 2080. The maps on Ixodes scapularis should be published in spring 2024, and the one on West Nile viruses will be published a year after. So in conclusion, well, we believe that this program enables several benefits to strengthen capacity in terms of adaptation to zoonoses and climate change in Quebec. Surveillance activities and research projects provide knowledge to guide the preventive action of public health authorities, decision makers, and other actors in Quebec. And knowledge transfer activities increase alertness of the public health network and the importance of deploying preventive measures. Here is a slide of acknowledgement. And I thank you very much for your attention, and I'll be happy to answer questions.
That's great. Thank you very much, Ariane. Again, people, you can post questions. There's one there I'm going to come to in just one. I'll ask it first, actually, because I think it ties in. So somebody's asking around some of your KT and your publications. Are they in both official languages? And the second part of that question is, are there any plans to collaborate with other national organizations? And by national, you mean the rest of Canada? Because I know in Quebec, national means Quebec.
Very good question. We have some of our work that has been translated in English, not all of it, unfortunately. We more and more we try to publish in CCDR, so then we get that translation in French and in English. But we are always open to collaborate. I mean, and if ever you have question on one of the publication which is in French and you want to exchange in English on these publication, we can find a way to do it, obviously. And regarding the collaboration with other provinces, we do actually. I have some examples in mind. We are working on the surveillance of mosquitoes responsible of West Nile virus, for instance, and we communicate with all the province to verify what type of surveillance they are doing. Well, I would say same with rabies work. We try to communicate with other provinces to exchange experience, exchange knowledge, and find the best way to do the surveillance and interpret the data.
That's great. There is a follow-up to that in terms of, I don't recall if your last slide had your email address, and if not, maybe we can share that with everyone. One of the things you touched on early in your slides is you talked about, all of your expert groups using the One Health approach. Can you talk about your sort of experience and how that went in terms of applying that approach and getting people to think about it, and any benefits or challenges you may have experienced in sort of using that model with your expert groups?
Yes. Let me think about an example to illustrate the idea. The Observatoire is actually the group where we have the longer history of One Health collaboration. We work, for instance, on the projection map of Ixodes scapularis, to project in the future, considering the climate change. So, of course, we're used to work with a human health expert and animal health expert, but with the Observatoire, now we had the environmental expertise, so we are actually looking first at how the temperature will influence the establishment of the tick. But now we want to see how the forest will change with climate change, and if the forest will really be suitable for the establishment of ticks. So the climate can be very good for the tick establishment, but maybe the environment will not be. So this is a way where we try to really add the expertise from human health, animal health, and environmental health. I hope that I answered your question. Yeah. Okay.
No. I mean, I think it's an interesting, because it's an approach and a concept that's been around for a while. But I think when that term gets used, not everybody is familiar with it, or how do you, theory and application are often very big divides. So we do appreciate that. I don't know if you have any last thoughts or comments you'd want to make before we sign off.
Well, just maybe the idea of this talk was really to share with you what we are doing in Quebec, and we would be very happy if you contact us and if we could collaborate and exchange in the future.
That's great. Thank you very much, Ariane. We very much appreciate your presentation. And with that, we'll say thank you and we'll move to our next presentation. Thank you very much, Ariane.
Thank you.
Okay. So just bear with us 1 second while we have our next presenter join us. So our next presenter is Dr. Kaylee Byers, who's going to be presenting on Connected Yet Disconnected, exploring how social and environmental determinants of health are integrated within One Health. So welcome, Kaylee.
Thank you so much for the introduction, and hello, everyone. Typically, I would be joining you from Vancouver, Canada, but today I'm actually joining you from Louisville, Kentucky, on the lands of the Shawnee, Cherokee, Osage, Seneca, Miami, Hopewell, and Adena peoples. And I'm actually joining you from another conference, the Wildlife Society Conference, where I've been presenting a version of this work to wildlife managers and practitioners. And I was also speaking at this conference about chronic wasting disease. And so I wanted to thank Dina for talking about chronic wasting disease. It is a very urgent and growing issue for the health of our wildlife, our cervids in Canada, and certainly a food sovereignty and safety issue. And a huge thanks to all the speakers so far today for their wonderful talks. So today I'm going to be posting or speaking about collaborative work between my institute, the Pacific Institute on Pathogens, Pandemics, and Society at Simon Fraser University, the Canadian Wildlife Health Cooperative, of which I'm Deputy Director in British Columbia, and the Lincoln Park Zoo in Chicago. What is One Health? One Health is the interconnected health between animals, people, and the environment. This is a graph that an image that we created for a publication on One Health and environmental justice last year. And what I love so much about One Health is that One Health is about the sides of the triangle and not the tips of the triangle. So when we're thinking about One Health, it says your health isn't just about you, it's about the health of the animals, it's about the health of the environment, and it's that interconnectedness that's important. And when I say the sides of the triangles, what I mean is that it is our interactions with our environment and with animals that influences health outcomes, not just zoonotic health outcomes, other health outcomes as well, like mental health, environmental stress. And it's in these connections that we can find solutions to these challenges. And I did want to highlight that although One Health has just been recognized in Western science within, the last 60 years, this idea is not new. This is from a paper from 2020 talking about the need for a One Health approach to manage COVID-19. And it is by Joe Copperjack and colleagues, which highlights that One Health echoes Indigenous principles, these principles of interconnectedness. So not a new idea. And I come to this work as a wildlife health scientist. I started out in wildlife health. I spent a decade tracking rats and the diseases that they carry. And now I work with deer in chronic wasting disease. And what's really important about these systems and what One Health allows us to do is see the environmental and social upstream determinants of health outcomes, not just for us, but for the animals as well. So here's a graph from that same figure or from that same paper showing that, if we say have health outcomes in species like rats, that there are social determinants that underline where we would see those health risks or risks for people from those animals, like housing and infrastructure, the ability for rats to get indoors, green space availability, pest and waste management that allows, say, animals to thrive with food available to them, policies and governance that dictate what that waste management looks like, as well as environmental determinants like species distributions and how animals interact with each other, changing climates, population dynamics of vector species. All of these things are interconnected. And so when we're talking about those upstream determinants, that many folks on this call will be well familiar with social determinants of health and environmental determinants. And there are other determinants as well, like commercial determinants. We'll focus on social and environmental today. But social determinants are those non-medical factors that influence our health outcomes in positive or negative ways. They are the forces and systems that shape the conditions of our daily life. Here you're looking at two images from our collaborator, Julia Smith, on this work, who runs the Gender and COVID-19 project, that has looked at how COVID has disproportionately affected women or people who identify as women in many ways throughout the pandemic through, say, caregiving responsibilities. These social determinants include things like gender inequities, income inequities, racism, food insecurity, housing, affordable health services, government policies, unemployment, and job security. When we think about environmental determinants of health, this is a quote I love from the Canadian Public Health Association that underlies, again, our connectedness to the land. The relationship between human beings and the ecosystems of which they are a part is profound, right? We often don't think of urban spaces as our environments, but they absolutely are. And so environmental determinants of health include things like pollution, resource availability, water, clean water especially, and climate change. And so we've been really curious, our team, around how the social and environmental determinants of health have been considered within One Health research. For a field that is meant to be interdisciplinary and to draw on diverse ideas, do we actually think about these upstream determinants of health, and how have we framed them in the literature? On the right, you're looking at a figure again from that paper led by Dr. Maureen Murray, and it's an example that I really like that shows all of this interconnectedness, and it is outlining algal blooms or harmful algal blooms. So when we have increased nitrogen and phosphorus in the environment, it increases the number of algae, which can emit toxins. Those toxins can paralyze wildlife in the environment, which has a negative impact on the communities that rely on those animals as part of their economies. And it also impacts human health as well, the toxins released from these organisms. And all of this is determined by waste management, the policies that dictate waste management, and land stewardship. So again, we're looking at systems here. So how have these systems, or how do we think about environmental and social determinants within One Health systems? So we did a systematic review where we looked for evidence of manuscripts that talked about One Health. There are similar frameworks like planetary health and eco-health and One Welfare. We looked for those too, and terms such as social and or environmental determinants of health. On the right, you're looking at the number of publications by year, and you'll notice that the number of publications has increased with time. That's not surprising. Again, these are relatively new concepts within the realm of Western science and the use of these terms. And we found a total of 201 papers, of which we included 103 that were relevant. And on the left, what you're looking at is the breakdown of the number of papers that are research, reviews, and opinions. And what you'll notice is only about a third of these manuscripts are actual empirical research. Another third of that is just us talking about how it's important to incorporate these ideas. When we look at the breakdown of social, environmental determinants of health and both, most of these papers talk about social determinants, fewer talk about environmental determinants, and a few papers talk about both. So mostly a focus on social determinants of health. I wanted to give you a couple examples of how these things have been integrated within the research aspect of these papers. This is an example from one of the manuscripts looking at community-based approaches to Chagas disease, a parasitic disease transmitted among people and animals by kissing bugs, Triatoma. And they did this study in Bolivia, Guatemala, and Mexico, and through surveys and conversations with people, found that people were most likely to have Triatoma in their home, and therefore a risk of Chagas, based off of housing quality, where they were located in the village, either on the periphery or inside, the habitat type surrounding their home, and the abundance of animals like dogs and rodents, which can serve as a reservoir for these pathogens. And based off of this, they were able to identify some potential solutions like window screening, education, cleaning of the home, rodent control especially, and overall community empowerment and knowledge to support a reduction of risks. In another example, looking at biosocial approaches to helminth diseases, these researchers looked at Taenia. It's a helminth that's transmitted among people and pigs. And what they found is that folks would, the social factors such as gender and income inequity were influential in determining risk of Taenia infection. Women were more likely to know about the life cycle of these animals, for example. And environmental factors like clean water, So clean water meant you were less likely to become infected, and sanitation overall. So whether or not you had a latrine in your home. And based off of what they found, even though consuming raw pork was a risk, it is also a culturally important practice in the community. And so they were looking to other alternatives, perhaps through improved sanitation, vaccination of pigs, and medications for people. But this came back to the social determinant of income and access to resources and needing to address those. So these are just some examples of how people have been incorporating the ideas of social and environmental determinants of health within the research. And I wanted to highlight, like I said, about a third of these papers are just opinion papers. And there was one study that actually looked at physicians and veterinary students and the training they had and how they thought about environmental and social determinants of health. And what these researchers said is that our findings suggest that MD and DVM students are unaware of many factors that impact patient health outside of their own discipline. So not necessarily aware of those upstream determinants of health, and they're not thinking about these factors outside of what is immediately in front of them within their own discipline. And that's a problem, again, because One Health is actually meant to be interdisciplinary. That's the connection between animals, people, and the environment. And so based off our review, what we found is that integration of One Health frameworks with social and environmental determinants is certainly seen as important, but there's less evidence that it's being put into practice, at least when it comes to actually framing the terms as social and environmental determinants of health. And we think that this means that we need more training of health practitioners across that nexus of health in the upstream determinants of health. We need interdisciplinary collaboration to escape our disciplinary silos and to mobilize this research and action and intervention multi-sectorally, and to integrate quantitative and qualitative methods. We need mixed methods. These studies that I spoke of earlier blended both community knowledge with those quantitative measures of risk. And so I want to thank you very much again for your attention, and I'm happy to take any questions.
Sorry about that. It was too many screens and most couldn't figure out which way it was going.
I get it.
So thank you very much, Kaylee, for that. And thank you for joining us from, well, I guess you're not probably any farther distance than if you were in BC.
Maybe not.
One of the questions I had is, early on you talked about the social determinants, but in your work, have you looked at maybe in one of the examples was obviously on gender, but have you looked at any disproportionate impact on equity deserving populations that maybe, we have a lot more recent immigrants from some countries that have maybe are experiencing some of those diseases, but have you looked at, or are you thinking about looking at sort of the impact on different equity deserving populations?
That's a really great question. So this, again, is sort of like a preliminary look at how we've been thinking about these issues. But collaborators of mine have certainly been leading some of that work. Dr. Chris Schell out at the University of Berkeley has done some really exciting work around the legacy impacts of like redlining, for example, on like wildlife in these communities. There's wildlife health specialists, but looking at sort of those connections. But that's not work that we have done ourselves yet.
No, I mean, obviously it's a newer area, but again, it's one of those add-ons. So we have a few questions rolling in. So thank you for your presentation. What would be a good starting step for local public health agencies in terms of One Health approach?
That's a really good question. I think it's partly just about starting to build those relationships. A researcher actually just asked me this question as well. How do we do this within research? And I think it's starting locally and finding connections across the discipline. So if you're in public health, looking for collaborators in the veterinary and environmental scope, maybe at a regional scale to start building some of those relationships so that we can mobilize when we do have relevant health issues.
In your work, do you find that there's still a lot of everybody works kind of in silos, like environment versus climate change versus, do you find that, and maybe what have you found works well in breaking down those silos?
I have, because I think I started out, even though I'm not a veterinarian, I've mostly worked with veterinarians up until maybe the last 5 years. And there's tons of really great One Health work that happens within the veterinary field, but it stays very siloed. A lot of vets are still just talking to vets and they're not talking to the public health folks. I have found, again, sort of the relationship piece to be maybe the most important. And I think maybe coming back to like when we think about a problem, to map it out and to try to think really broadly about it so that we can start seeing the connections. One of the problems is we might not immediately see where there's potential for collaboration, but I think if we zoom out on an issue, it gives us a lot of opportunity to start seeing, you know, where is there other expertise here that can help understand this issue.
Great. So I've got a couple more questions here. So are there any organizations currently taking on the process of educating healthcare providers regarding the One Health perspective and implementing it into patient care?
I don't know. I mean, certainly that we have a medical program that may be starting at Simon Fraser soon, and we've been talking about planetary health as one of the guiding principles of that. I'm not aware of any there is quite a One Health focus for veterinary professionals at the University of Guelph, and they actually have a whole One Health program now for undergraduates who might go into MD or DVM programs. But I do still think that training is lacking, particularly in the human health space.
Great. So 2 more questions. Bear with me with this one.
Yeah.
So do you think governments will stop siloing sectors from one another? When the forestry economy began in BC, government funded research to find a way to increase the growth of coniferous trees used for lumber. Without consulting any other fields, they began spraying pesticides to prevent any other flora to grow other than coniferous timber. This now has impacted the biodiversity of the forest while also increasing the spread of invasive species and parasites. Is there any research regarding these impacts from other sectors?
Oh boy, if I knew what the government was going to do. I have no idea. I hope so. I do think that the One Health ideas are actually also getting into government, and there's some really great work, like the Community for Zoonotic and Emerging Diseases, for example, uses a One Health lens, and that's sort of at the national level. But that particular issue, I'm not familiar with in terms of like mobilization within One Health concepts in government.
Right, and I know there's 2 more questions here, but I think maybe we'll ask them quickly. So thanks for the great talk. Most of the work in One Health appears to be focused on animal environmental impacts on human health. How do you think we can expand these One Health approaches to better consider animal health and environmental health as important as their own right?
Yes, thank you. And actually, because I come from the animal health space, I think the real area where we need more focus is environmental health. It seems to me that environmental health folks are the ones who are most often left out of these conversations. There are perhaps more natural connections between the human and animal health because of zoonotic diseases. That's another problem I actually see with the One Health work, is it's very focused on zoonotic diseases. Mm-hmm. Understandably, but there's so many other environmental factors that contribute not just to zoonoses, but other health outcomes. So I think I'd really love to see more attention to bringing in and being inclusive of environmental health practitioners.
Well, and I think you touched on the point the last person is making here around, have you examined the One Health approach related to non-communicable diseases?
Yeah, we are thinking about that, especially and how to broaden outside of communicable diseases. I will say the money is in the zoonotic disease space, but I think it's really important for us to be thinking more broadly about health generally. That's
great. Thank you very much for all the questions. Thank you very much, Kaylee, for joining us, and we appreciate your presentation.
Thank you so much. Thanks, everyone.
Thanks, everyone, for bearing with us and going over. I apologize to the next speaker. We went over just for a few minutes. So our next speaker is Colonel John Grabenstein, who is presenting on global geotemporal global geotemporal distribution of Chikungunya disease from 2011-2022. Here
we go. Let me check connections.
We can hear you, John.
And the video should be coming in soon, I think.
And we can see your presentation. There you go. Yeah, we can see you and we can see your presentation.
Great. Thanks very much for the invitation to come join you today. My name is John Grabenstein. I am twice retired, and I run a little consulting company called Vaccine Dynamics. I'm on the eastern shore of Maryland, so that's the great estuary of the Chesapeake Bay. And I want to thank the folks who pointed out the nativelands.ca website. It lets me recognize the Susquehannock and Choptico peoples who were the original peoples of this land. I also want to say thank you to the translators who are the ones working hardest today, I think. So merci beaucoup for that. One of the jobs I have now is working with a little nonprofit called immunize.org, which helps with people who operate in vaccination clinics, pharmacies, medical offices. And every year at the 1st of July, we always run an article comparing or explaining to Americans the Health Canada and all of the immunization aspects of your country. And then similarly on Mexico's National Day, we do the same thing for our neighbors to the south. One of the most fascinating, I'm a pharmacist and an epidemiologist. One of the most fascinating courses I took in my graduate program was in medical geography. And so that, put some of that work to use today and in the paper that I've written. Had 27 years in the U.S. Army, had 13 years with Merck Vaccines, our affiliate, formerly Merck Frost in Canada. Had lots of interactions with Defense Canada and Health Canada, and always really good interactions. So chikungunya is not a disease of Canada. So let me take you away from Canada for a little bit. As you travel south to gain some sun or some warmth from time to time, it is a hazard you might bump into. So something to consider. The virus is an alpha virus. The virus and the disease have the same name. It's a mosquito-borne disease. Aedes mosquitoes spread it as they do yellow fever and dengue and Japanese encephalitis. It is a disease with an abrupt fever and severe joint pain. The word chikungunya comes from the Makonde language of Eastern Africa. It means to become bent, and it refers to joint pain, joint swelling, rheumatologic complications that can last months to years, and is the reason that this is not a disease that you want to contract. But it's a fascinating case of space and time and human behavior all interacting to make it very complicated to explain where the risk is and how the risk varies over time and over geography. So what we did was we compiled data from the World Health Organization and its regions, from various national governments, from the literature, from PubMed, from Gray literature, and started building maps. And I'm going to skip the words here and go to and stay on the main map that was the result of our work, because this picture is worth well more than 1,000 words. But after a considerable amount of work, this is how we decided was the best way to depict the issue. And I'll start down here in the legend to give you a bit of explanation. Chikungunya comes and goes. It is a sporadic disease, and it is one that causes explosive outbreaks when it gets into a population not previously exposed to it. There had been a time when it was only really recognized in Eastern Africa and on the island of Réunion, which is a French territory on the eastern side of Africa. But the virus spread, and the Aedes mosquitoes that are the primary vector are distributed worldwide, but the virus had not been. But as you see here, the virus has now escaped a relatively concise geography and is now spreading around the globe. So most cases are from tropical and semi-tropical areas. As you can see, Canada is completely white here. The whole circumpolar region is. And so this is definitely or stereotypically a tropical disease. And yet, lately, there have been a set of cases around the northern coast of the Mediterranean Sea. So one of the boxes calls out some cases that are that have developed in certain departments of France or states of Italy and the like. And so we see the amount of disease rising. But these are still very unusual cases, problematic, but unusual. And it's India and Brazil and Sudan and Thailand and a variety of the other countries that you see that have the highest number of case reports lately. And that's another issue, is if you look, you can find it. If you don't look, if you don't test, if you don't have a good surveillance system, if you don't have a way for feverish illnesses to be reported to the National Reference Lab, like might happen in lesser developed parts of the world, then you may not know what's fully going on. So the first limitation of this study is we've described what's been reported, but we don't know what hasn't been reported. So, so the deepest blues are what we call, the deepest blues are what we call substantial numbers of cases and recent ones. And I've called out several of those already. The medium blue, and so look to Mexico for that color, is what we call many cases, but less recent. So for example, in the Caribbean and in Latin America, there was a large outbreak in 2014, 2015. And so all of, the northern tip of South Africa, South America, Central America, up through Mexico, even a bit in Texas and Florida, had cases then during that outbreak, but the number of cases recently is far smaller. Then the lighter blue is what we call sporadic, so that's Chile and Argentina, Pakistan, a variety of other places that we call sporadic. Now, the hashed gradations are where there have been reports in the past, and the mosquitoes are still present, but no recent reports or few recent cases reported. Am I confident that there's not transmission going on in Central Africa that's not counted, not reported? No, I'm not. I'm confident that it is happening. I'm not confident that a low number of reported cases is the actual description of what's going on. But I want to call out the limitation, another limitation to what we've done, which was we've given countries one color only. And so you can imagine that the geography, the topology of the climate of Chile varies a great deal from top to bottom, and similarly Argentina. And I'm going to show you, we had data from India so that we could look within the states of India and do subdivision rather than just look at one national total to get risk itemized a little closer. And so that's what you see on this slide with the states and the various colors. The two deeper large countries on the west coast, Gujarat and Karnataka, are actually the medium color in this group. That's group 3. And the group 4 countries are actually relatively small, or states and territories are actually relatively small geographies, and so they don't show up quite as prominently. My colleague Aditya Singh Tomar is a native and a resident of India, and so I said to him, Aditya, explain to me what's going on here. What's the pattern? And he said, well, I see one pattern. It's the Himalayas don't have many mosquitoes. That's the white states in the north. And other than that, I don't see a pattern because this is Odisha and Chhattisgarh states over here with, all in all, relatively, there is no particular pattern by altitude or by socioeconomic status of the province or the degree of attention from the provincial government or the state government. So, how much of this is the range of the mosquito? How much of this is the presence of the virus? How much of this is human behavior is all unexplained by us, certainly at this point. So let me, we've written this up in a publication that was published recently in Travel Medicine and Infectious Diseases, if you want to go into this in greater detail. But let me come back to the main map for the sort of some closing points, and then we'll take questions. Chikungunya is an episodic disease, and so, but one must look for it all the time, consistently, if one is going to be able to catch the early waves of an outbreak. This depiction is whole nation coloring, and there are certainly limitations to that. I forgot to point out the V's on here are the vector that there are Aedes species mosquitoes, or Aedes genus mosquitoes in all of those places, and so the geographic range of the mosquito is broader than where the disease is. And this is a climate change conference, so of course we are worried about climate changing such that the range of the mosquitoes could become broader. And this map will need to be revised as time goes by to reflect changes in disease incidence, and hopefully better surveillance, more consistent surveillance, so that we can best understand where the risk of the disease is. So let me pause there and see if I've triggered any questions.
Thank you very much, John. I think on my screen your video has paused, but I think we can hear you, so that's all good. Your very last point in terms about, where the mosquito is, appearing in the disease, but I guess if you could use a bit of a crystal ball and think about, how that maybe has changed in the last 5 years, and you being in Maryland, is there thinking about more surveillance and monitoring as you go further north into the US and into Canada, or is this still something relatively vague because it seems to be elsewhere?
At the moment, I am advocating for just more testing in Puerto Rico, in our Caribbean possessions, let alone, working our way further north. In doing this research, we found a variety of articles, and they're cited in the paper, looking that were more entomological assessments of what's likely, in climatological assessments of how do we expect temperature to change, how do we expect the mosquito range to change. And of course, they're all speculating, and I would do no better than that, and that's not even my field. But this is just one disease. The Aedes mosquitoes carry many diseases, and just as the previous speakers talked about tick ranges and that sort of thing, and it's a similar kind of issue that where will the vectors find good habitats. And then as the humans move around, someone with the virus in their blood finds the new mosquito in the old mosquito in the new place, and suddenly you have an introduction, which is basically what happened in the Caribbean and Latin America in 2014, and now it's endemic in Brazil and will be for a long time.
So I think you've kind of answered this, and this may be a more direct. Do you see a threat of chikungunya in Canada in the near future, considering the rapid climate change?
Not within your borders, your travelers. Yes, but and so we were working with the U.S. CDC trying to understand what the reported cases are. So the U.S. state with the most reported chikungunya cases was New York. Not because there's disease, but it's because that's where the travelers originated from. They didn't have their destination in the database, which is what we really wanted to know. Similar to a question, it was the Lyme disease BC versus Ontario question, I think, was the comparable question.
And I think someone just commented that the Albopictus is established in Windsor, Ontario, but the chikungunya risk is exceedingly low. Right. So one quick final question in terms of the impact of COVID. I know your numbers are generally from 2019 to 2022. Did you see, if you looked at a smaller sample, like was there less during COVID, or nothing's really changed?
Yeah, so thank you for raising that point. We presume that international travel was drastically reduced in 20 and 21 and even 22. So most of these cases are endemic cases, autochthonous cases. They're the residents, not travelers. So it's a Brazilian risk to the Brazilian people, an Indian risk to the Indian people. But as you know, if you go there and you stay long enough and you spend enough time outdoors, well, some of these mosquitoes are indoor mosquitoes. Then you begin to gain the vulnerability or gain the susceptibility that the residents have. Most of this is resident cases.
Perfect. Great. Thank you very much, John, for your presentation and taking time out of your day to discuss this with us, and we very much appreciate it. So thank you.
Thank you.
Okay, everyone. We're moving to our next presentation. Get John to stop sharing his screen. I think that's worked. So our next presentation is, sorry, I have to look at my notes. I'm in the wrong spot. Is Dr. Stephen Drews, who's going to be talking about understanding the epidemiology of babesia in Canadian blood donors impacted by changing climate and environment. And with
Hi,
that,
can you hear
Stephen?
me?
We can hear you.
My headset broke today, so I'm in the blood center, so there's a little bit of background noise. I don't know if you can see my slides. I'm just changing them, sorry, right now.
No, we can not yet.
Okay. So far, can you see them?
Not yet, not on my end.
Okay, maybe I have to do something here. Okay, maybe I'll try this again. Okay, how about now?
Yep, there we go.
Perfect.
We can see your presentation screen yet.
Excellent.
Yeah.
And I've just moved to full screen. Can you see that?
Not yet on my side.
Or am I still stuck in this?
Yeah, it looked like there was a resume slideshow, so it might have just been the format. Maybe if you click on that button again and
Okay.
just a slight delay. Yeah, up at the top I can see resume slideshow.
Okay, maybe I'll click on it one more time. Sometimes this happens when I work with Zoom.
Well, maybe what we can do, if you want to, maybe not the best, I don't know if you have notes, but maybe you can just leave it in this format.
Okay,
we can see. Yeah, I just click through the slides. It's not as smooth for you, but I mean, I think it works.
Sorry.
No, it's all good.
Happened to me occasionally. So my name is Steve Drews. I'm the Associate Director of Microbiology here at Canadian Blood Services. I'm also a full professor in lab medical pathology at the University of Alberta. And I'm sitting in the Donor Center in Edmonton in Treaty 6 territory. I have two conflicts of interest. One is that I'm advisor to Roche on emerging pathogens in malaria, and I'm also a member of CERN as a co-investigator. So for this presentation, attendees should be able to identify the role that blood operators such as Canadian Blood Services play in the healthcare system. We'll talk to you a little bit about how climate change may impact on our practices as blood operators and the risks for transfusion transmitted parasites that we assess for. We'll understand how blood operators take risk-based decision-making processes, and then quickly go over how we might carry out further surveillance for babesia and blood donors. So blood operators are the groups that collect blood and blood products. So in Canada, there are two primary blood operators. One is Canadian Blood Services, and the other is HEMA Quebec. And we're responsible for collecting fresh blood products from volunteer donors. We're also responsible for ensuring the safety of the blood supply. We ensure the safety of the blood supply using a variety of different processes. The processes that I'll talk to you about today are largely based on vigilance and surveillance. Those are the components in red. However, we also undertake good lab processes or production processes. We have donor engagement and trust, lab testing for some pathogens, and we do donor studies and risk assessments as well. So we also undertake research or surveillance at Canadian Blood Services, and this is because we have access to residual blood specimens. We have specimens that are from repeat and first-time donors. And we also do follow-up look-back trace-backs. There's a blood research program, and we have the ability to assess donor demographics. Climate change is something that we're quite concerned about, in particular the long-term aspects of climate change and how that might impact on blood supply as well as blood safety. The one component of climate change that we're looking at is the impact on Ixodes scapularis ticks, and this is a review article that we've taken this image from. And one of the concerns is that as we see changing climate, we'll see increased ability of the Ixodes ticks to move into areas such as Alberta and Saskatchewan, where they currently don't have long-term populations, and then understand if this poses a risk to blood supply for things such as transfusion-transmitted babesia. I sit as the co-chair for the International Society of Blood Transfusions parasitology subgroup. And we actually take this topic quite seriously. We recently undertook a review of climate change and the parasitic risks of blood supply internationally. We found it too early to provide specific recommendations to blood operators, but thought that we should maintain our vigilance, in particular, looking for changes in the epidemiology of transfusion transmissible parasitic agents such as babesia. Babesia is an intraerythrocytic protozoa or parasite. We primarily think of Babesia microti, but there are other species. And in nature, this is primarily transmitted by a black lady tick of the genus Ixodes, although there may be other ticks that transmit as well. Why do we care about babesia as a transfusion-transmitted disease? There are relatively few cases. Most of them have occurred in the US. The numbers are still quite small, but they can have a fairly high mortality rate. The concern is such that the FDA in the US has recommended, or I should say stronger terms, told blood operators that in states where that babesia is endemic, and there's a group of these states, they will have to undertake testing for babesia and donations, or use a red cell pathogen reduction technology. And at this point in time, there are no red cell pathogen reduction technologies that are FDA or Health Canada approved. Canadian Blood Services has undertaken two babesia surveillance projects, and I was involved in the 2018 project when I joined Canadian Blood Services, coming from public health. In that study, we worked with HEMA Quebec to identify a prevalence in donors that was probably between 0.002% and 0.007%. These rates were approximately at the levels of U.S. states where there was no mandate for donor screening with PCR or nucleic acid testing. At that time, we also identified that we should be looking at doing a further risk-based decision-making process. We did a risk analysis with our epidemiology group as well as HEMA Quebec, and that led into our RBDM, or risk-based decision-making process. We found that the rates of the risks would be relatively low for transfusion-transmitted babesia. The key takeaway here is we would probably be looking at a base scenario about once every 12.5 years, given the current rates of infection in Canada in particular. However, this led us to do a further risk-based decision-making process just to make sure that we were covering off on our bases. A risk-based decision-making approach is developed by the Alliance of Blood Operators and folks at Canadian Blood Services. And it allows us to look at the existing data and go through a series of processes of participation, problem formation, engagement with stakeholders, assessment, evaluation, and making a decision. For this, we looked at several options, whether we would undergo further surveillance activities, whether we would undertake further prevalence studies, and essentially what that does is basically allows us to determine the most appropriate pathway for the blood operators to take, taking into account these varieties of factors to ensure that we're agile and still protect the blood supply. So essentially, those went from surveillance out to further engagement internationally, in particular with the U.S. blood operators, and also maintaining vigilance and education with the general microbiology and infectious disease community. What we did find is that as we were undertaking this, we did see a pattern of changing epidemiology for babesia, as well as other agents that are transmitted by Ixodes ticks. In particular, we published a report just during the pandemic on a donor who was positive for babesia. In that case, the donation did not lead to transfusion transmission, but allowed us to engage across several jurisdictions in Canada and increase the understanding of babesia, transfusion transmitted babesia as a risk to blood supply. The other possible transmission route for babesia, particularly on the West Coast, might be through Dermacentor albopictus. And if we were to take a further surveillance program, that we would take into account the fact that this is also a winter biting tick, and that we might need to think about a different surveillance strategy on the West Coast, where traditionally we look for the babesia with PCR in donors in the summertime period. This epidemiology, I don't think, has still been completely elucidated, but there are concerns that as we look at the West Coast, that we see that babesia duncani and also these albopictus ticks here might be establish themselves on the West Coast, particularly in areas of King County and Seattle that are south of the U.S.-Canada border. And really, that's very borderless if you go to that area near Abbotsford in particular. From our surveillance program, we also identified seroprevalence signals for individuals, particularly in the southwestern Ontario region. When we did our surveillance program, we didn't see nucleic acid test or PCR positivity in that group, but we did see evidence that individuals may have been exposed to babesia in the past. This falls in with our current understanding of Ixodes tick activity in that area, in particular southwestern Ontario. And so this would be an area that we would consider a potential hotspot for further surveillance. So capturing information like this and then deciding with our colleagues in the public health community whether we would need to think about undertaking a surveillance plan with blood donors in those regions. We also saw a signal during the pandemic where we engaged public health in the Kingston area about anaplasmosis And again, this bacteria is, not a parasite, of course, but it's intracellular, and it can be transmitted naturally through the bite of an Ixodes tick. So this is another signal here where there have actually been, descriptions in the literature and in the gray literature, and this, of course, is a potential transfusion transmitted agent, although the data signal for that is not as strong as what we would see with babesia. We've also seen some data signals for babesia anaplasma in the region of Nova Scotia south of Halifax. And so with this information, we've started to think about, where are the areas that if we were to undertake further surveillance in the future, where would those areas be? And in particular, would we undertake specific targeted surveillance for regions that were considered hot zones? So the hot zones would be, southeast Manitoba, maybe British Columbia, parts of southern Ontario, and then the region of Nova Scotia south of Halifax on the peninsula. So a plan might look like this, and this is something that we're thinking about doing at Canadian Blood Services. We've had some discussions, but a plan would most likely focus first on that area in southeastern Manitoba, in Winnipeg area, and focus on a June to October sampling, because we think that it would be likely through Ixodes scapularis ticks in that region. However, that would still in future years potentially have a similar temporal strategy for Nova Scotia, southwestern Ontario, and maybe southeastern Ontario, with a different strategy looking at full season surveillance in British Columbia, where we might see different epidemiology. So I just see if I can, I'm not getting this one here. So what are potential surveillance strategies? I think we need to think about surveillance using both PCR and serology approaches. Of course, I've been discussing mostly babesia, but we should also think about Anaplasma powassan virus and other tick-borne agents and their geographic vector distribution. Some people will actually look at Lyme disease. Lyme is not, there's no evidence that Lyme is transfusion transmitted, but Lyme sometimes acts as a a marker for early Ixodes activity in that region, and may actually lead babesia introduction into specific areas. And that's it. So I'm happy to take your questions, and sorry for a little bit of the technical problems here.
Thanks very much, Stephen. This is probably a dumb question. I won't say naive. It's probably dumb. But so in terms, you'd mentioned the transfusion transmittable. How long does, and because you touched on at one point a little bit how people had markers for babesia before, how long does it last in, because the blood is live, obviously live product. How long does it last? Has that testing been done? Like, is it safe after a certain amount of time, or just basically the product is disposed of?
Yeah, so in red cells, so red cells would be the component that would be the most at risk, because of course bees are going to be within the erythrocytes. Occasionally there may be some residual red cells and platelets. There's nothing really, no risk really to frozen and thawed plasma, and then plasma going for fractionation is not a risk. We haven't really looked at I mean, there is some data out there. You would consider any unit from an individual for the ones I've identified as if you had a donor that walked in and said, I just had babesia, you would be doing a look back investigation on those donated products, and checking to see who received what products and when, and also looking at the clinical scenario with the donor. And in fact, you can that one paper in Vox Sanguinis that we present actually goes through how you would do that type of investigation. The only way really to ensure that a product would be safe would to do pathogen reduction on it. So residual red cells and platelets there are pathogen reduction methods that could probably reduce babesia titers by 6 logs. The problem for red cells is the current pathogen reduction technologies are not don't work for red cells or for whole blood, and so there are techniques that are being developed that do DNA cross leukemia using non-UV light approaches, but those aren't there yet. So really, anyone who comes and says, I donated and here's my donation time and I just had babesia, you're going to do that investigation.
So, obviously Blood Services has been testing blood and monitoring for various, bloodborne infectious diseases. When did climate change really kind of become something that Blood Services started thinking about as a little more of an important factor in terms of looking at your own products and what you're doing?
I think we've always kind of looked at that. One of the roles that we play is just general surveillance of the existing medical and scientific literature to get an understanding if the epidemiology is changing. And we know that, for example, we test for West Nile virus using a PCR. We do that on travelers. And then in a season that's about 6 months, summer season, we test every donation. Probably since that point, I would say, watching the potential introduction of that virus into North America and changing climate as well as changing vector patterns was a pattern. But I think we've been doing that ever since the start. Just being vigilant for changing patterns in pathogens, in particular ones that we don't currently test for because there's no significant signal, but we have to keep vigilant for. So I think something we've always done, but it has ramped up. We do lead One Health discussions at the AMI-CACMID meetings, which are the microbiology ID meetings. We try to have those yearly. We introduced those a few years ago as workshops, and those are things where we try to talk with the larger public health and ID micro community on One Health changes.
The one final question before we wrap up here, I guess it's specific to a slide. It says, what were the risk-based decision-making processes, recommendations, 3, 4, 5? Can you, I guess they couldn't quite see them.
You can go back to these here.
It's like a slide 7, yeah.
Yeah. So we would essentially look at our environment, and if we did see changes, in epidemiology, we would have to decide whether they were significant enough to do changes in nucleic acid testing. And when we do those, we should also be looking at things such as the safety of the blood. What are the operational risks? What are the budget impact? What do stakeholders say in the ethics and social analysis? And ethics and social analysis is actually really important because you have to decide where the tipping point is. And, if you spend money on something where the risk is not really there yet, or are you taking funds away from something where there is a risk? And so our ethicists will actually talk about that type of thing. And so it's, cost effectiveness, not for saving money, but ensuring that you're using those resources in the most appropriate way. This one here, so given babesia's relationship with climate change pressure points, we should be developing stronger engagement with our colleagues in infectious diseases. And this is something I do as a co-chair for ISBT's parasitology group. And I also involved a lot with AMI-CACMID, some sessions. They do it annually. So that's something we bring up there. And then just with our leadership, talk about at Canadian Blood Services, what the changing patterns might look like. Because not just for babesia, but climate change has other non-infectious diseases risks. So if you lose a road and you have a truck stuck behind a washout in British Columbia someplace and you can't get your product out, there are products such as platelets that need to be, processed and moved through the system. Blood needs to get to the sites to be processed within a specific amount of time to have proper testing done. And so there's a whole bunch of other things that happen that climate change can be impacting, and not just infectious diseases risk. But my job as a micro here is to really look at that and to do that broader engagement. I hope that's a bit clearer here.
Great. Thank you very much, Stephen, for your presentation. It's very much appreciated. I know personally, I think having something like blood service, which is not inside the normal box thinking for some of us, it's good to see that work is going on. So thank you very much.
Thank you.
And thanks to all our speakers this afternoon for presenting their work, and we very much appreciate it. I know we're a little bit over time, folks. We'll be back at 2:45 Eastern time, so in about 15 minutes for today's final speaker. So thank you very much, everyone. And